Good morning, everybody. Welcome to our second Durant technical panel on COVID-19 response in low resource settings. Thanks to our panelists and the discussants and all of you in the global health community for joining us. This is our second panel. We're hosting it to try to address the unique challenges that those of us working in low resource settings have in responding to COVID-19. We're trying to bring together our experts who are in Boston, our global health experts, and questions and answers from you in the field, hoping to exchange ideas and find solutions to respond to the global outbreak. We're planning to continue these panels every week. This is just a snapshot of a few of those of you who are joining us. Thanks very much for being here. We're going to record this webinar and we'll post it on our global health website. At the very end of the session, we'll make sure that you have the website where you can find it and share with your network. Let me introduce the lineup. So I'm Louise Ivers. I'm the director of the Mass General Hospital Center for Global Health. We'll have Dr. David Walton speaking with us, Dr. Erin Richterman, and Dr. Fortunate Atwine. We also have Dr. Kerry and Dr. Ronan as additional discussants during the session. I want to encourage you to use the Q&A feature. If you're online on Zoom, please use the Q&A feature to submit questions to us. The chat is a little bit harder for us to keep track of, but the Q&A will be able to, and we'll try to get to your questions as we go. So we're going to start off with our panelists giving kind of rapid flash updates on some of the key thematic areas. We'll talk with you about some of the questions you've submitted already online. And then, as I mentioned, try to get to as many of your questions as we can during the session. So we're going to start with Dr. Erin Richterman. Go ahead, Dr. Richterman, thanks.
Thank you, Dr. Ivers. Thanks, everybody. I'm going to take a couple minutes to highlight a few updates from the rapidly emerging COVID-19 literature. Next slide, please. I want to start with an update on what we know about the spectrum and severity of disease. A little over 3 weeks ago, the China CDC published characteristics of the epidemic in China in JAMA, you can see in the upper left corner here, showing a distribution of diagnosed cases as shown here, with 81% mild, meaning mild pneumonia or non-pneumonia, 14% severe, meaning shortness of breath, elevated respiratory rate, hypoxia, or worsening findings on chest imaging, and 5% who required critical care. In the upper right corner, you can see that in Italy now, we are seeing a similar breakdown among diagnosed cases, with about 25% severe and 5% critically ill. We are also seeing in the table on the right that, as in China, the mortality is heavily skewed towards older people. However, you can see in the figure below that these are data that were published 2 days ago by the CDC about the first 4,000 plus cases in the United States. Cases are broken down by age, and you can see hospitalizations in the lightest blue, then ICU admissions, then deaths. And while deaths are again concentrated in older people, there is a substantial amount of morbidity in younger people as well, with 50% of the ICU admissions occurring in people under the age of 65. The one exception to this is in children, and in the last week we've seen 2 large reports that included thousands of children from Korea and China who had COVID-19, and the very vast majority of them had mild illness, with only 1 documented death that I'm aware of in a child with comorbidities. Next. Finally, this is a figure from a paper published a couple days ago in Nature that attempts to determine the true symptomatic case fatality risk, which is shown on the y-axis. This analysis tries to work around the fact that previously reported case fatality ratio estimates may be biased too high if some symptomatic but mild cases are not being tested and identified, thus impacting the denominator of the equation, or biased too low because of the sometimes lengthy period between diagnosis and death, thus impacting the numerator. They found an overall symptomatic case fatality risk of 1.4%, again with the differential distribution by age, as you can see on the slide. Next. So there are 3 studies that have been published in the last 2 weeks that have specifically evaluated for risk factors at the time of hospital admission for poor outcome in COVID-19. So in addition to older age, cardiovascular disease and hypertension in particular appear to confer elevated risk. And then there are a number of other laboratory biomarkers which may be useful depending on the setting for risk stratification, including LDH, D-dimer, and CRP. Next. So there are a number of investigational therapies being tested for COVID-19 right now, and I want to highlight just a couple that are already in wider use for other purposes. The first is lopinavir-ritonavir, which is an HIV-1 aspartate protease inhibitor. There has been interest in using it both because it has shown in vitro activity against one of the SARS-CoV-2 proteases, and because there was an open label study of lopinavir-ritonavir during the SARS epidemic that suggested there may have been a benefit, particularly when used early in the course. Next. That was the inspiration for this study, the first therapeutic randomized clinical trial in COVID-19, which was published 2 days ago in the New England Journal. It was an open label trial of lopinavir 400 milligrams with ritonavir 100 milligrams given for 14 days that amazingly enrolled 200 patients in about 2 weeks at the end of January at a single hospital in Wuhan. Their primary outcome was improvement on a 7-point ordinal scale ranging from death to discharge. At enrollment, participants were a median of 13 days into illness, which is important. And 70% required oxygen, 16% were mechanically ventilated at the time of enrollment. As you can see here in the figure on the left, there was disappointingly no difference in the primary outcome between the groups. However, there was a small difference in time to clinical improvement in the subgroup that received lopinavir-ritonavir within 12 days of symptom onset, suggesting that this agent might have a role if used earlier in the disease course. Stay tuned because there are a number of clinical trials in the process of answering that question. Next. So chloroquine is an anti-malarial drug closely related to hydroxychloroquine that has in vitro activity against SARS-CoV, potentially through binding of its target receptor ACE2 or through impairment of viral replication. Because of the widespread availability of this agent, there is interest in testing it for treatment and pre- and post-exposure prophylaxis for COVID-19. And while chloroquine has already made its way into many treatment guidelines around the world for COVID-19, including our hospitals in Boston, clinical data are limited to one low-quality, non-randomized, open-label clinical trial that was published just in the last few days that enrolled 36 patients at about day 4 of illness with mild or moderate COVID-19 disease. And you can see the figures below, that they found a greater decrease in viral load with hydroxychloroquine compared to lopinavir-ritonavir. There was also a question of a synergistic effect with azithromycin. Obviously, these are very weak data, and that randomized data are what we really need to urgently to guide management and the potential use of this agent. Next slide. So speaking of which, I want to close by just pointing to remarks by Dr. Tedros from the World Health Organization 2 days ago, where he announced the launch of a multi-arm, multi-country clinical trial for the repurposing of medications for the treatment of COVID-19. Countries as of 2 days ago that had signed on include Argentina, Bahrain, Canada, France, Iran, Norway, South Africa, Spain, Switzerland, and Thailand. In this trial, which is called the Solidarity Trial, there will be 4 arms compared to the standard of care. One will be remdesivir, which is another investigational antiviral drug originally developed for the treatment of Ebola virus. Second will be lopinavir-ritonavir. The third, lopinavir-ritonavir and interferon beta. And finally, chloroquine or hydroxychloroquine. So more to come on this. And with that, I'll turn things back over to Louise.
Thanks, Dr. Richterman, for that. Can you comment a bit? We've been hearing, in the news about non-steroidal anti-inflammatory drugs. Some people might historically have used steroids for severe respiratory illness. Can you help us understand where we're at in terms of the evidence around those two things?
Yeah, so as of now, so there are a few anecdotal reports about concerns for the non-steroidals. And then there was some comments in the news by one of the French health ministers, I think. But, basically from our standpoint, there's no evidence for or against the use of NSAIDs right now. And so from our standpoint and our guidelines, we're saying that they're okay for use, but kind of need more study. And for corticosteroids, there is currently no evidence to use them, and we're recommending against their routine use unless there's another indication.
Great, thanks very much. I just want to remind you, if you're in the audience, if you have questions, especially questions about treatment, and our own treatment guidelines are rapidly evolving here at Mass General. We just last night had some guidelines published for here and now, what we're doing today. If you have questions, please submit them. We'll come back to them. And with that, I'll pass it over to Dr. David Walton. Thanks, Dr. Walton.
Thanks so much, Dr. Ivers. Next slide, please. So I wanted to, with these brief remarks, really focus on a couple of things that really come out of the questions that you see on the slide in terms of thinking specifically about low resource settings and how we take best practices from past epidemics to apply to this epidemic or this pandemic. And the other realities that we may confront in low resource settings in terms of cohorting patients. When you don't have the ability to test, testing is something that I think this forum will address specifically in the coming weeks. But right now, there are many countries that either don't have testing and or don't have readily available testing. Thirdly, protecting caregivers, with scarcity of PPE. And fourthly, when we think about infrastructure and sort of potentially COVID treatment centers, how might we address that? Next slide. So I really wanted to first talk about PPE, and we'll go through this quickly. What you see on the slide here are the current recommendations for the ideal scenario, right? You need a gown, either disposable or washable, eye protection, or face shield, gloves, surgical mask. N95 is good to have, but not necessary. You could use a surgical mask, but it's really necessary to protect the healthcare worker if you're doing things that are going to potentially aerosolize the virus, including, but not limited to, CPR, intubation, and things of that nature. And then in terms of how you place the patients or where you put the patients, again, if you have private rooms where you can put that patient, that's great. It would be, again, ideal if you had a negative airflow, but again, most of the settings that we're thinking about might not have that. And so a private room with the door closed is ideal, but I'm gonna talk about in a couple minutes alternatives to that. Next slide. So then we come to the reality of the situation, and this is one of the questions that I received last week, which is, what do you do when supplies are quite limited? And so, and then the following slides, I want to review what the CDC, the Centers for Disease Control here in the US, have really put out recommendations. And to my surprise, they're incredibly pragmatic and I think very realistic regarding the limitations that I think many are going to have, particularly in low resource settings, but also potentially here in places like Boston, where shortages of PPE are ever present. And so the face mask mitigation strategy, it's okay if you've taken the proper precautions to wear the same face mask if you're in a place where you're seeing a set of COVID patients, right? So you shouldn't go from a COVID positive patient or a suspect patient to someone who's having a heart attack or non-COVID related. It's also recommended potentially, if you need to, that if your mask has a manufactured shelf life or manufacturer designated shelf life and they're expired, try to use it. Again, these are in settings of shortages. And again, if it's soiled or removed, it's important, if it's soiled or damaged, important to remove it and not use it because it could put you at risk. And then as always, because the face mask is protecting you and you might encounter droplet nuclei, you really want to avoid, it becomes a fomite, so you really want to avoid touching it. Next slide, please. How about when there are no face masks available? A true reality in a lot of these settings. So one very pragmatic thing is, if you have older clinicians, and when I say clinician, I don't mean just doctors, nurses, whomever, patient care assistants, whomever is really interacting with the patient, if they're at risk, if they're older, if they have comorbidities, you might want to think about not having them taking care of COVID patients. Another possibility is to use patients caregivers who have had COVID and have recovered. So this is taken really from one of the successful strategies in the Ebola epidemic, with the assumption that when you have COVID and recover from COVID, that confers a level of immunity. There isn't confirmatory data to support that, but that's sort of what I think most people are believing. And then again, if you don't have a mask, but you do have shields, you can use a face shield. And then finally, again, much to my surprise, but very much consistent with some of the reality of these settings, if you don't have anything, potentially a bandana, a scarf, something just to cover your nose and mouth. Again, We don't know how effective that is because it's not considered PPE, but in a pinch, it's something that you can think about. Next slide, please. Gown mitigation strategies. If you have cloth gowns, and many of these settings do, and you can use them again after washing them, ideal. Again, using expired gowns if they have an expiration date. And then extending the use of gowns, much like we talked about with masks, in terms of if you're going from COVID patient to COVID patient to COVID patient, you can keep that same gown on. Next slide. If no gowns are available, again, trying to exclude caregivers who may be at very high risk, lab coats, patient gowns, if you have them and you use them as protecting you, sort of reusable lab coats, aprons, long sleeve aprons in combination with patient gowns. I mean, there's a whole host of things. And really the takeaway of this slide is just try to protect yourself with something, whatever you might have, that is going to protect, again, you as the caregiver from exposure. Next slide. And then finally, eye protection, really critical. Again, really because you're protecting your sort of the mucosa in your eye that can potentially receive the virus, the droplet nuclei. Again, you can keep the goggles or face shield on from COVID patient to COVID patient. Again, if they're damaged, you want to remove them. Don't touch your eye protection, again, because they will become a fomite if you're going from patient to patient. Next slide. If no eye protection, using safety glasses, trauma glasses, you really want to be, eyeglasses aren't recommended, but if there's a way to sort of have some side protection with the glasses, I mean, that's also one of the sort of key points of entry. And then again, this sounds like a broken record, but excluding clinicians who may be at high risk, and then using sort of survivors, convalescent clinicians who may have recovered from the virus. So next slide. Again, I reviewed that quickly. It's on the CDC website. The link was at the bottom of the page, but it is really, really critical that we think about these contingency strategies, given that in many areas there is not going to be any PPE available whatsoever. The next thing I really want to talk about is cohorting patients. And what I mean by that is, how do you take your patients who are coming to your treatment center, who are suspect for COVID, and group them in a place that is not with your other patients who may not have COVID or don't have COVID? Women who are there for prenatal visits or delivery, people who are there for emergent surgery, someone who has an abscess, etc. So with this particular model that I'm going to talk to you about, there are a couple of assumptions. One is that your patient volume is high, and you may not have the ability to segregate or cohort patients in your existing facility for whatever constraints you might have. IPC might be a challenge in your facility. You don't have ability to segregate your ambulatory patients, or you need a separate area to house these patients or to see these patients, either as part of your facility or as a standalone facility. And when you think about these, you can think about them in terms of sort of the things that other epidemics have used in the past in terms of cholera treatment centers and Ebola treatment centers. Next slide, please. And so here you see a schematic of what this might look like. And I'll just highlight a couple things quite quickly. Number one is all patients, regardless of what they might be coming for, should be screened with a screening questionnaire. If they don't meet the criteria, they should go right to your main facility. And if they do have meet the screening criteria, then they can potentially enter into this fenced off area and go into an area for triage. This model that I'm proposing here assumes you have the ability to test. We'll talk about a no testing scenario in a second. And so if they go into triage and they potentially have COVID and you can test them, they'll go in and they need to be hospitalized, they can go into the suspect ward, etc. If you go to the next slide. And so this is really the flow chart. So entry screening, do they meet the screening criteria? Yes. If they do, then they go into triage. If they don't need to be hospitalized and you have the ability to test, you should test them, AKA in an ambulatory fashion, counsel them to self-isolate and watch out for symptoms, and then send them home with a plan for follow-up for their testing. Next slide. If they do meet criteria for hospitalization, then you would put them in the suspect ward. The suspect ward is essentially a hospitalization, a sort of a temporary hospitalization, where they are awaiting their test results. And if they're positive, next slide, then they can be either hospitalized, or if you have the ability to put them and they're clinically unstable in a high acuity unit or an ICU, then you would do that as well. If they're SARS-CoV-2 negative, they could go, and they need to be hospitalized, they can go back to the main hospital. This next scenario was that the next slide? Yep, yeah. This next scenario is a scenario with no testing. And so the same thing happens, but instead of being tested, you're essentially, next slide, you're moving into an area in which you don't have testing, and so your ability to sort of discern whether people have COVID or not is really a case definition. It's a screening. It's more than a screening tool. It's a robust sort of questionnaire similar to Ebola that you have, and if they meet those criteria, you're going to assume that they have COVID, and you're going to either, again, send them home if they don't need to be hospitalized, or hospitalize them immediately without the ability to test, and presumptively treating them, as many places are now doing, for COVID. It's important to understand that with this scenario, the chance for missing patients who do have COVID, or like patients who might have malaria or TB being put into a COVID unit, that's realistic. That might happen. But trying to be realistic around sort of the limitations that you might have, this is a scenario in which you might think about it. Next slide. And then in terms of infrastructure, one of the things that I do when I'm not treating patients is thinking about infrastructure. And so when you think about temporary infrastructure, which many of you may need, thinking about how to do that, what you see here is a schematic design of a potential sort of temporary unit where you're laying a concrete slab to make sure there's no flooding if you're in a flooding area. And then, it's essentially 2x4s with plastic sheeting around it, with some beds, an area for donning and doffing for staff, some toilets, and really basic care. Ideally, you're either going to be able to deliver oxygen via cylinders or oxygen concentrators. A key component of that is making sure you have power, reliable power for those patients. Next slide. And then the floor plan is very simple, right? You have as many beds as you can fit that is safe, so 3 to 6 feet apart, to sort of maintain your infection and prevention and control protocols, and making sure the caregivers are appropriately donned in PPE when they're in the unit. So those are sort of the things that you can really think about, and I'll turn it back to Dr. Ivers.
Thank you so much, Dr. Walton. I want to take a little pause here before we turn to Dr. Atwine to answer a few questions that have been coming in. One is about the use of infrared thermometers, which I think are very helpful, and certainly where they're available, having a no-touch approach to screening your patients. Any place where you can conserve your sanitation system or your PPE is a good one to use. So if you have access to infrared thermometers, I think they are ideal. I want to talk a little bit about testing, because we've had a couple of questions about testing, and obviously the ability to test is part of appropriate triage, and also appropriate containment of the pandemic. We need to be able to test, we need to be able to detect where the infections are, both to be able to treat patients, to be able to protect the patients who are not infected, and also to trace. I just want to, because we have a variety of participants with a variety of backgrounds, just go back to basics on testing. The two main kinds of testing are going to be to test for the antigen, to test for the virus itself, or to test for antibodies to the virus. And at the moment, a large focus on testing is around PCR, trying to detect the antigen. But we know that, doing that in a laboratory, it's very manually intensive. Not all laboratories can do that. And so increasingly rapid test kits are becoming available to test for the antigen, to test for the virus. There are also test kits becoming available to test for the antibody. I think the key piece will be understanding how exactly to use antibody testing. It's helpful in surveillance, it's helpful in understanding who has been exposed but asymptomatic. But what we need to understand better is exactly how these test kits perform. Are they of high quality? Are they, are they really doing what they say they can do in terms of detection, in terms of sensitivity and specificity? But also we need to remember that there's a lag time between getting infected with the virus and generating an antibody. So I think there's lots coming down the line in terms of test kits. I know there are a number of companies who are producing them. I know scientists in Boston who are studying their validity. And I think within a week, I think we're going to have a lot more information. We're hoping next Friday to have some specific discussions about individual test kits and what we know about them and what we don't know about them. But Dr. Walton, if you have a person in your screening triage area in the scenario where you don't have testing available rapidly, do we propose that all patients coming to the clinic or to the health center are received by a healthcare worker in full PPE? Is that what we're proposing?
Yes, that's correct. And I apologize. I'm trying to make sure that we keep my comments brief. I think my recommendation would be that at that screening point, your staff that is doing the screening is in full PPE and frankly is 3 to 6 feet away from the patient. Again, similar to how screening points were during the Ebola epidemic, sort of not quite sort of rinse and repeat, but using that model moving forward. Because again, you want to make sure, you don't know who you're talking to and if they have symptoms or not, and you really don't want to put that staff member at risk, especially when they're screening and you're getting all comers, and you don't know when they stand in front of you before they speak to you whether they have symptoms that may be COVID related or not.
Thank you. And another question I'll pose to you, Dr. Walton, before we move on. Dr. Rashid is asking if an inpatient ward is as you have the picture up, is that better option from private rooms, or is this, if and when you surpass your number of private rooms, can you walk us through that a bit more?
I can, and so again, I think private rooms are ideal. Certainly they're comfortable for the patient. You can, if you have enough PPE, you can don and doff, but you don't necessarily have to if you're going from COVID patient to COVID patient. But, of the hospitals that I have been to, whether it's here in Boston or in many places around the world, if the scenario of the number of patients increases to Italy numbers or China numbers or South Korea numbers, and I would hope that wouldn't be true, but it might be quite realistic, my assumption is the number of private rooms will be quite limited and you may need to move to a ward type scenario. So I would say if you have private rooms, you can handle the private rooms, and your infection and prevention control protocols are up to sort of leveraging your private rooms, I would use those because those are fantastic. Again, making sure you're keeping the door closed at all times, except with entry and egress of care providers. But when you exceed that, then a ward scenario might be quite helpful.
And there are also, you may have mentioned this, but there are also opportunities to conserve PPE if you have cohorted, confirmed positive COVID patients in a ward like this one on the screen. Then you can have healthcare workers in PPE in the room for a more prolonged period of time, whereas going in and out of individual rooms can be a high use on the PPE. So thank you for that. We still have more questions we'll come back to, but I'd like to move on to the next slide and our next speaker, joining us from Uganda, Dr. Atwine, who's the chair of the nursing department at the Mbarara University of Science and Technology and our longtime colleague. Welcome, Dr. Atwine. Thank you.
Thank you so much. I'm going to talk about nursing workflow during a pandemic, infection control procedures, and best practices for staffing. We are responding to COVID-19 response, and we work with Ministry of Health with guidelines, and we are working with District Rapid Response Task Force. And in the ideal practice, we would like patients to remain at home, and maybe they call upon when they need help, so that we minimize human traffic to come to the hospital. And if they come to the hospital straight, and we shall see how we are going to do triage at the main gate of the hospital of Mbarara Regional Referral Hospital. And we work together with MAST. The District Rapid Response Task Force, it works with the District Health Officer, and then in connection with, next slide please. We have the surveillance focal person, and also we have, but at the moment, currently today, no case has been registered in Uganda. Next slide, please. Infection prevention and control. We are following Ministry of Health guidelines, and the Regional Referral Hospital gate has 3 gates, and we have initiated hand washing material, and we are planning to have a triage center where patients are going to be screened. Number 1, a brief history to know where they are coming from, whether they have contacts or not, or whether they have any link that they have been traveling abroad and they are coming back. We also need to have temperature using the infrared thermometer, but at the moment we don't have. Then a brief physical assessment. Next slide, please. In case we have, those are the things that I've been talking about. They are locally made, but there is soap and running water. We are happy that we can have, but we have tablet or soap. We don't have liquid soap, but we are using that one. Next slide, please. Staffing. We are planning to have 25 personnel per day to handle any outbreak. We have nurses, doctors, cleaners, security, scouts. These scouts are supposed to lead the patients in case they are identified, so that they can be guided to the isolation unit. We also have lab personnel and also the drivers. Next slide, please. The flow of clients. Suppose that we get any case, then is guided by scout to the isolation unit. And in the isolation unit, we have 1 permanent building, but others are temporary structured units, of which I will be explaining. When the patient comes, they take off laboratory investigations. Here we are using nasopharyngeal swab, laboratory specimen, and also oropharyngeal swab. Those at the moment are the laboratory investigations that we are taking off. And then they are taken to Ministry of Health in Entebbe. Next slide, please. So those are some of the parts of isolation. We have the nurses during orientation, how the patients are going to be brought in isolation, and that is the isolation unit. And above we are showing how PPE, but it is partial, not full PPE, how we are dressed, and how if we were to get the patient before real admission on the ward. Next slide, please. Admission procedure. We have 3 categories. Number 1, we have suspect. And what do I mean? These are the people who might show clinical signs. Another bullet, please. Then we have probable. This is somebody who has a link with contact person with the condition, and also clinical signs and symptoms. Another bullet. Then the third category is cases, confirmed diagnosis. So when they come, okay, next slide, please. Planning for very sick patients. We understand that if we have maybe patients admitted, we expect quarter of the patients to have severe condition with respiratory distress, and these need ICU. At the moment, we are planning to have ICU in the isolation because these patients cannot be taken to the general hospital in ICU unit. The isolation unit is small, can only accommodate few beds, and if in case we get patients, the permanent unit is the one to be installed in with ICU equipment, and then because it is very difficult to nurse very sick patients in temporary sheltered with canvas material, the other units I have talked about. Then we are yet to equip isolation with respiratory ventilators, and we pray that COVID-19 does not hit us here at Mbarara. If it hits us, it will be really very difficult to manage because we are not yet ready to handle, and resources are not yet, we don't have enough at the moment. We are using the surplus from the previous experience of Ebola. Next slide, please. Thank you so much for listening.
Thank you so much for spending the time to share with us. I'm constantly reminded that this is the year of the International Year of the Nurse and the Midwife. And so many of our health workers around the world are nurses and are really on the forefront of this. I want to ask you, Dr. Atwine, if we assume that there's a large volume of moderately ill or severely ill patients, do you have a plan to change your flow, to change your layout? How are you anticipating that circumstance, or are you still working on those plans?
Yeah, yesterday we had a meeting. I have mentioned that we have one permanent building. We are planning to shift the nurses station outside so that we bring the ICU equipment in that building in separate rooms of that permanent building. The rest are temporary shelters outside other units.
Thank you. And has the hospital begun yet to cancel routine visits or to limit routine visits? One of the viewers earlier asked us about kind of routine exams, routine physical exams. How do we know? And of course, I know that Uganda has not reported a case yet, at least as of last night. So correct me if I'm wrong on that, but let's presume that there in time become some cases. How do you know if an ordinary patient is actually an asymptomatic COVID patient? So are you beginning to think about canceling routine visits or postponing elective activities?
Yeah, we are going to have triaging centers at the main gates, 2 main gates. In case we get people with probable signs, they will be put in isolation units separately. And those who, suspects and probable, those who have link, they will also go in another separate unit. And also those who are going to be confirmed, they are also going to be put in another separate unit. But now Uganda, as I talk now, they have prohibited the schools. All schools have gone home. The university is closed. Even church people don't go to church to minimize congregation, large congregation of people. And we are informing people, should they have common cold or something cough, they should remain at home. There are some helplines. call, and then people find them at home who can bring them to the hospital.
Thank you so much. Please, do stay on the line with us, because I know we're going to have more questions coming in. I must say that I'm heartened by the very aggressive preemptive measures that we're seeing in countries that either are in the pre-epidemic stage, like Uganda with no cases, having a large movement around social distancing, and yesterday Haiti recorded 2 confirmed cases, and immediately major social distancing initiatives were put into place, which I think is going to be an important way for us to be able to get ready to scale up the testing, do the tracing, and do the containment. I want to go back to answer a couple of other questions. Someone had asked about how is it that HIV seems to be a platform for treatments. I think that one of the reasons why there's some mechanisms of action reasons why lopinavir, ritonavir is being considered for COVID-19. I also think that it's really important for us to look at medications that are already available, that are already tested in humans and known in humans. We know the side effects, we know they're safe, because we want to be able to both study new drugs, but there's also a pragmatic challenge with new drugs that they have to be tested for safety, and then they have to be massively scaled up. Someone asked about using chloroquine en masse and the problem of chloroquine resistant malaria. I think for most countries, actually with just a small few exceptions, chloroquine is not widely used as a first-line treatment for malaria. Although in Haiti, chloroquine is actually still widely used for the treatment of malaria. But I think we're at that moment in the pandemic where we may have to think about antimicrobial resistance issues later, and use the treatments that we have for the biggest problem that we have right now. I want to go back to Dr. Richman for a second, because we hear a lot about the percentages of people who need ICU care, and obviously for planning, understanding what the clinical profile looks like, how many people are moderately sick, how many people are severely sick, how many people need an ICU. I think you touched on this, but could you go back to what we know so far from in terms of studies, just so folks on the phone can be thinking?
Yeah, thanks for the question. Yeah, I think what we've seen so far among the identified cases, it looks like about 5% or 1 in 20 people are going to become critically ill, and many of them are requiring mechanical ventilation, being put on a ventilator. And the people who are most at risk for that tend to be very on the older side, particularly over 70, 80 years old, and with comorbidities. In particular, we're seeing cardiovascular disease and hypertension as risk factors that have come out in the couple of recent studies.
Thank you for that. I have a couple of questions for Dr. Walton. I'll just list a couple of them, because I think a lot of obviously what we're trying to deal with right now, both in Boston and around the world, is how do we manage our limited PPE supply. But one of the other questions that's, I think, really at the forefront of our mind, especially in populations where there's a high population density, and the ability to socially distance or to self-isolate is in some ways materially impossible, as we've spoken about in our group. How can we advise about spreading within families for people who are at home, maybe mentioning what we're recommending here, where you do have space, how might we adapt that? And yeah, I think it's both socially distancing, and the self-quarantine.
No, it's a great question. I just want to go back to, I think, Dr. Rashid's question with a footnote. When the question, just to remind everyone, was how do you leverage if you have sort of private rooms or individual rooms, how can you leverage them? The only thing that I would add to my previous comment was, if you do have single occupancy rooms and you're treating COVID patients, you want to make sure that those single occupancy rooms are sort of grouped together. So, it makes a difference, because if you have an isolation room on a ward, for example, you don't want to sort of just leave the room treating the COVID patient and walk through a ward where everyone else does not necessarily have COVID. So if you're able to group those rooms together and then actually create a barrier where you have to go in to this COVID area, I think that would be ideal. Back to your question, Dr. Ivers. So this is a very, very tricky one, particularly so if you sort of look back to sort of the patient flow that I had, I made the assumption that countries are not going to be able to take people out of the population. So China, one of the ways in which they've driven down their epidemic is that when you tested positive, you didn't go home, you went to somewhere, a big gymnasium where they held 1,000 people who were suspects and or potentially positive, and they sort of fed them and housed them, and they were there. And the reason for that is because there has been some data to suggest, which makes sense, that around 70 to 80% of cases are spread through close contacts, right? With an R0 of 2 to 2.5, that makes a lot of sense. And the pragmatic sort of answer is it's really, really difficult to separate your life when you're in close quarters. Refugee settlements are certainly sort of a very extreme example, but even in places like Uganda or Haiti or Tanzania, where families are tight-knit, living in close proximity, it's very, very difficult. The one thing that you might do, with the assumption that potential testing is available, which is, again, testing is a dicey subject, is to be, if there's a mechanism for active case finding and for follow-up, those people can both monitor their symptoms and follow up with care providers and potentially get tested. It's particularly tricky if you have people at risk, as Dr. Richterman noted, at home, who you may be at risk or infected and you're going home with your grandparents or whomever. And so to the extent that you can distance yourselves in a home, that would be ideal, but it's just really, really challenging. And I don't think there's a great answer to this question. So I'm certainly not going to pretend like I know the right answer.
Yeah, thank you. We're joined by Dr. Vanessa Kerry, and she's been listening to all of these conversations and discussions and following very closely. And I'd like to turn to her for a moment for reflections and thoughts about the workforce here, or other comments that you'd like to share with us, Dr. Kerry. You're still on mute.
Thank you. Today has been a very challenging Zoom day for many reasons, but I have been listening all along, and I want to thank the previous discussants for what I think is a really extraordinary, series of points and important pieces of information and what is rapidly evolving. And I especially appreciate David, Dr. Walton's reflections on sort of ways that we can be really strategic, whether it's in the United States or in a resource limited setting or anywhere, in how we can help mitigate the pressures on protective equipment and certainly on and families. And I think the workforce is a very serious issue in a number of ways, because in many places, this is going to be a global issue as we look at the workforce. And increasingly, the workforce has been getting infected at a higher percentage of the population. You see that a little bit through the arc of some of these epidemics. And certainly we saw that in Ebola in the end, that the workforce was very, very vulnerable. And we expect that'll be the case in COVID as well, especially as we're seeing a lack of PPE being able to be available. And the reports here that I just talked to a colleague in Seattle, where they're being asked they go through a whole protocol of cleaning their mask, and then they put it in a paper bag where they walk between rooms with it in a paper bag, but it's kind of shuffling in that paper bag, right? So it doesn't feel like that's gonna be a very protective method. So I think these ideas of creating sort of COVID wards and cohorts where we can move between are going to be very strategic and make a lot of sense. And hopefully we will also be able to make PPE more available globally. In the programs that I have partnered with, in sub-Saharan Africa, the real issue has been, actually in some cases there are empty ICUs with equipment fully monitors, beds, everything's been donated, and there's no staff to be able to work within those units. And I can think of at least 2 or 3 in Uganda alone that are like that, for example. And so one of the requests and challenges that we've been asked is, how do we scale up the ability to train existing healthcare workforce or to recruit additional workforce out of the private sector or elsewhere who can be trained in the use of this equipment and critical protocols around COVID. So obviously management of respiratory distress, management of sepsis, management of cardiovascular collapse, which we are seeing happens with some higher percentage in these patients, renal failure. There's a lot of issues that kind of span medicine, but it's not just the things that are related to COVID, because women are still going to be having babies within this new COVID world. What is the data around how we protect neonates that are born? Do you separate a mother who may be symptomatic from her child? So there's a whole series of questions that need to also be answered and protocols put in place. And so I think that, but training folks to be able to address these COVID particular sort of needs is actually an opportunity to scale up training across the board, because these issues will continue post-COVID in patients who come in for other reasons. And so I think there's a really great opportunity to not only acutely respond to the emergency and the pandemic in training, but to think, take that one extra small step to think about how do we leverage this to have a resilient and lasting investment that we can really capitalize on when we get through this emergency. Obviously, prioritizing what we expect to see will be a huge influx of patients in the short term. So we are going to be looking to try to build out some modules that will very specifically focus on issues related to the clinical needs and mentorship, and not just deliver them, but re-deliver them and try to create a system of ongoing mentorship, even if it's through remote and telemedicine. Because one of the things we know, and I am certainly guilty of this myself, I will remember for an hour after my continuing medical education course everything I learned. And then a week later, I'm going, what is that fact? And I think we want to be able to provide support through the arc of what this pandemic is going to look like in many settings.
Thank you so much, Dr. Kerry. I think your point about the crowding out of other pieces of the health system is really critically important, something for us to think about. We know that during cholera outbreaks, other health issues have to get sidelined. We saw in West Africa after the Ebola, or during the Ebola outbreak in 2014, 2015, that some estimates had that there was 4,000 additional maternal mortalities as a result of the outbreak, that there were 1.3 million additional malaria cases in children, because all attention is appropriately put into the issue at hand. But I think there are perhaps strategies we could address where we try to protect some health centers as non-respiratory illness, where you try your best to protect spaces for the issues like pregnant women delivering. The availability of rapid test kits is really going to help us to do that, so we can appropriately triage. We have just about 5 or 6 minutes left, and I wanted to each of the panelists have you think about a question that we keep getting, excuse me, about the use of community health workers, about the use of youth volunteers, about how can we best use community health workers, excuse me, or volunteers in the context that we want to protect them. We don't want them to get sick. We also don't want them to inadvertently be transmitting the virus. So how can we use them? And maybe I'll go to each. We have a few minutes left, so let me do one thing before I go to each of you. I want to tell our audience, thank you for joining us. We are planning again next Friday at the same time, same place, to dive into technical issues, to talk some more about community health workers, to talk some more about testing. So please join us then, but I will also use up the last few minutes for comments on community health workers from each of our panelists. First, I'll go to Dr. Walton.
Thanks, Dr. Ivers. And this is a really great question. And as I think about community health workers, I think about them as part of the care continuum of a functional and robust system, and particularly helpful where hospitals, sort of the limits of a hospital or a care facility end, right, which is typically at the door, and everything else happens in the community. And so I think you leveraging and utilizing healthcare workers for screening, even if potentially down the line, if there's surveillance with rapid tests, what an incredible tool to be able to do that. I do very much hear and understand and share the concerns around how to protect those healthcare workers. They're going from place to place, from house to house, from family member to family member. Again, as you said, Dr. Ivers, trying to prevent them from being a vector themselves. I do think despite the critical shortage of PPE, we need to offer them PPE. They are an extension so they're part of the fabric of the healthcare network. They're no different, therefore we should treat them no different than any clinician who would be encountering a patient or a potential patient. So, you know, the same IPC protocols that we have in the hospital, should be trained on them, and they should be extended to them. To the extent that we have PPE, they should get the PPE. Again, keeping things, you know, washing their hands, staying 3 to 6 feet apart from folks, etc. That sort of baseline, sort of, I think, for everyone moving forward. But I do think leveraging them as much as possible, because I don't think there is any way for any country, including the one I'm sitting in, to really get a handle on this epidemic if we're only relying on facility-based interventions in order to sort of stem the tide. And so I think for countries that have community health workers, utilizing them, keeping them protected, and keeping them safe is imperative.
Thanks, Dr. Walton. Maybe I'm going to pass the last couple of minutes of the microphone to Dr. Atwine. I want to, again, thank you for joining us. We have a lot to learn from our colleagues in Uganda. That's true any day of the week, but I think it's especially true when we know how successful you have been on the front lines of epidemics like Ebola and contact tracing, and also historically very used to syndromic management and triage, and also used to managing challenges and resources, which for many of our colleagues in Boston have just never experienced. So can I give you the last word, Dr. Atwine, and thank you for all your service, and let us know about your thoughts on community health workers and how they can be engaged.
Yeah, thank you very much. Community workers would be a good strategy, but then this is a new disease, quite different from Ebola, although they are somehow related. But before we really fully engage them, I think they need training of the signs and symptoms, and also good practices. But now we cannot call them and teach them. We are in a dilemma of what to do. We cannot call them together and teach them. The best option may be, we cannot find them in public places. We are yet maybe to go and in a meeting and think ways, because now I cannot conclusively say that we take it, because our people need sensitization. Although we send messages on radios, but I think it is not enough, because change of behavior is different from what people hear on mass media. So that is a good strategy, but we are going to think how best we can use the community health workers.
Great, thank you so much. We're going to end the discussion here. There were a couple of questions that were not answered, but we'll try to make sure that we can link on our own website to some critical sources of information. You can see more about SEED Global Health also. Their Twitter handle is there, because Dr. Kerry and her team will be working on those modules. Some of you have asked, when will they be available? How can they get them? We're working in real time to try to get the information out and share as much as we can. So please stay posted and join us again next week if you can. Thanks everybody for joining us, and have a good day.
Thank you.